Dr. Shabana Chaudhary is coming here. Trevor Girls Medical College, Yatawar Medical Complex, Peshawar. Our co-chair is Dr. Shabana Chaudhary. She's chairperson and head of Department of Pediatric Ophthalmology, Children's Hospital, Lahore. So our first presenter is Dr. Shama Khan. She's professor of the Cornea Department, Al Shafa Trust Eye Hospital, Rawalpindi. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Dr. Shama Khan, Professor, Cornea Department, Al Shafa Trust Eye Hospital. The video I'm going to show you is about the scleral patch graft, which we did in a patient who had trauma with screwdriver. At that time, his repair was leg repair was done only, and 2 weeks later, he presented to my clinic. Well, this is how the eye looked. The legs were swollen, the sutures had been removed. There was a resultant subconch hemorrhage, and we can see there was anterior chamber reaction, and only positive finding that was of concern was a black spot at 12 o'clock. The consent from the patient was taken for his video to be shown. So we decided to explore. We did the parative defect, arrowhead in shape, which was extending beyond the insertion of the superior rectus muscle. So we decided to disinsert the muscle. We tied it just the way we do it in squint surgery with the help of 7-0 vitral. The muscle was tied. And it was cut at with the help of scissors and small snips. Now the fibrovascular tissue surrounding the defect was removed. We took the graft from the corneoscleral rim and it was made thin so that it doesn't cause much of the surface irregularity. Initially, the patch which is taken is of larger size. We put the first anchoring suture. It is a bit difficult to apply because the graft is very mobile. We use 7-0 vitral. And then we tailored and cut it according to the defect. This is the second suture. This is basically the strength determining suture. And we have to be very tight. We want the graft to be as close to the host as possible so that not only the wound is sealed, but the surface remains smooth after the surgery. We have to take care that while doing dissection and the cryo, you should be doing minimal dissection so that it doesn't cause much of the inflammation afterwards. That we have to take care of. Now the 4 cardinal sutures are in place. And then the rest of the sutures are applied. With 360 degrees surrounding the graft, prophylactic cryo. Because the eye had inflammation, the time has already passed and we didn't want the retinal detachment afterwards. The superior rectus muscle was stitched back to its original point of insertion. This is the first one. That comes our muscle. graft, and the muscle of the tendon was then spread, and the conning tower was sutured. This is 2 weeks post-op. Gaze in all directions is normal. The patient has vision of 6/9, which was initially like 6/36. And the take-home message is whenever there is history of trauma and you have dialed, always go for exploration. You might find something that you can miss simply on the state examination.
So Sultan would want to add something to it as you'll be doing a lot of cornea, lot of
Wait for it.
Thank you, Dr. Sharma, for the wonderful video. There is a slight change. Dr. Majid Malik requested for an early presentation because he is already he has another presentation in another room. So I'm inviting Dr. Abdul Majid Malik sir, who is a professor of ophthalmology.
Thank you, Dr. Sarah, Dr. Sophia, and my understand audience. Actually, I have to come today because I am moderating live workshop. Generally, there is a consensus of the subject that in pediatric surgery in younger children, you should always make a suture, as you that is small suture. That makes the thing safe, and there's just some leakage is higher as compared to elder people because of elasticity of the cornea. In this case, and in most of the cases, children about 2 years, I don't do suture because while removing the suture, you have again to take the child under anesthesia. So we can avoid this thing. How? It is the bone construction. Actually, that matters. It should be 3-step LCM, self-sealing LCM. So, as we will do, we strain the cornea, the triangle blue, essential for the pediatric cataract. It is it's a good habit to do it other cataracts, especially if it is white cataract, but essential for pediatric cataract. The strain not only colors the cataract, it also makes the capsule a bit more stable as compared to a non-strain one. So you can make access more easily with less chance of running away of access. This too. Needle should be very, very fine. The tip should be small, not big. No, message of यहाँ पर available. So it is that fit, especially with high viscoelastic, like Protis. And if the chamber is well maintained, you have no problem. Hydration should be good. And the capsule lens should be well mobilized. Generally, these are soft lenses. They don't take much. And when it comes very easily, this is generally everybody does it, and it is not a special thing. Special thing is how to construct the LCM and how to seal it. And I have done so many of these tests without suture, and I didn't see any case with leakage in this suture. Because suturing is such a thing. Multiple lens is ideal. Why multiple? Because it prevents phimosis and it keeps the lens setting better than single big lenses. Multiple lens should be definitely given, and we should clearly make everything clear on the back of the lens as well. We should not leave any part of viscoelastic to prevent complications. These people are both prone to develop uveitis and glaucoma as compared to adults. So this is a major factor to initiate observation as well as to raise intraocular pressure postoperatively if left. Viscoelastic should be cleared from and reachable thoroughly. No hydration of the side port. The addition of the rear port generally is done by this hydration, but it is better to do it with this Simcoe. Place it against the board. It not only seals the sides, it seals the roof as well. So once roof and sides are sealed, board is safe and sound and does not leak. And especially once the board is fixed and deep and reached. The next day you see everything is safe. And it generally happens in most of the cases. I didn't see any leakage. Thank you.
Next presentation is by Dr. Akshani. She is head of department, and she has come all the way from Karachi. He reached last night.
Was a step of investigation, so I don't have much to tell here. So my emphasis is on 2 points here. So for gonioscopic examination, we generally don't recommend a dilated pupil. But when you are performing goniocentric lysis through gonio lens during the surgical procedure, you can easily have a dilated pupil. So you don't have to make your cataract surgery difficult by not dilating the pupil. The reason for that is that you have already established your diagnosis by pre-gonioscopic examination. So the second emphasis is on the fact that you need to do indentation gonioscopy because gonioscopic lysis is indicated only for the cases of synovial angle closure and not for the appositional angle closure. So you have to have an indentation gonioscopy in pre-op examination of it. So this data was really soft, so I had to use most of the time to take it out. So in this procedure, I'll be doing nasal 180-degree gonioscopic lysis. Variation aspiration. Okay, so after the implantation of the iron, you are going to put viscoelastic into the chamber to deepen it, to have a very good view of the angle and some gel on the surface of the cornea as well. So the lens that I'm using is actually the Swan Jacob gonio lens. So it's a gonio prism, and to have the view of the angle, you have to align your visual axis. So I'm doing nasal goniosynthesis, so I'm going to sit on the temporal side of the patient, and for that you need to tilt the microscope 30 to 40 degrees towards yourself, that is towards the surgeon. And the head of the patient will be tilted 30 to 40 degrees away from you, from the surgeon. So microscope towards the surgeon and the head of the patient away from the surgeon. So I'm holding the gonio prism, gonio lens in my non-dominant hand, that's the left hand in my case. And then I'm going to hold iron plane forceps in my right hand. So I'm entering here into the anterior chamber to the side port, so you don't have to make a new port for this procedure. So I'm pulling the iris away from the trabecular meshwork, but in the downward direction. So I'm actually trying to physically open the trabecular meshwork to facilitate the trabecular outflow. So it's very obvious that I'm touching the cornea, so it's going to be, some cases don't bleed much, some cases will bleed a lot. So you can always come out, wash your blood with, either you can disperse it with viscoelastic or you can wash it easily and then restart again. So here I'm trying to complete 180 on the nasal side. So this is one synchronizes same nasal side but from another vision because I think this was the better view. Again, entering from the side port, do not leave the mid port. Here you can see the vision is not that much. So you are not supposed to put the iris towards the pupil because you can cause iridodylisis. So you will hold the iris a little downwards away from the retina. So with one port, you are almost able to achieve 180 degree of GSL. So after it is done, you wash, I remind there is any and you move to the scholastic gel. One can expect fibrosis the next day. And the only way to prevent it is that you can take a motivated temporary at the end of the procedure. Thank you so much. Small message said that unicyclitis combined with pupil emulsification is less invasive than trachelectomy with of course less complications. So again,
we go with the 27 gauge needle with the heel on, and we just sweep with the finger, and there is no edema or bleeding or very little, which we can stop with just the indentation. So why don't you prefer that?
So most of the methods you will see are internet allergy tablets. So I'm not a fan of sweep procedure because I think it does not, give you the desired result in most cases. I personally think so. So I'm not a fan of sweep procedure in cases of GSL. It does not give you the desired result. I think it does not completely break up the sanity.
Can I just make some comments, please? Okay, so thank you so much for your talk. The main benefit of GSL is if your glaucoma is less than 6 months old or early GSL, otherwise
Not in the other cases,
the mesh is selected and it doesn't do very much. That's the first thing. The second thing is what I do mix is I usually before I put the after you put the lens or before you put the lens, you have no viscoelastic in the eye. I put the 2.5 to 6 in left frame because I am anticipating bleeding from any form of mix. So either that or 10% in left frame meet in the anterior chamber, and that does help your bleed. The third thing is I don't know which viscoelastic did you use. Do you use GV or can you give us the name of the viscoelastic? GV. And it's hard to get, it's more expensive, but it does help. And it's not easily accessible to most lot of extent. The point that you made, it's a very good point because I think you have used the MST forceps and micro forceps MST handle. I think you've used, right? Okay, you've used ILMP. I've historically used those, but I think what I have now switched myself because the GSL are not too bad. I do go with the cannula and I do try to sweep. And a lot of times because the colonoscopy you do or the slit lamp is often not as good as you do on the table because you have more, obviously you've taken the lens out and you have more viscoelastic available. So you have a good tilt and then you go and you try to sweep. If it doesn't help, yes, I would have the street sharper or the reinforce, whatever you use. Obviously, more expensive, and you open another kit, which you may get away with if you can manage to sweep the angle. Obviously, you have to, you have to be very tactful because you have to hold that cannula, and then you have to have plenty of viscoelastic and then sweep it around. you may get away with it. It does work. It does work, and it's quite good. The condition is your viscoelastic has to be a heavy viscoelastic. Use the basic whatever the other ones. They don't always work. Thank you.
So it is better not to hold the iris and pull it, right? You are adding more trauma to the angle and also causing bleeding. It would have been better just sweep either with the specialated iris depositor or the one she was talking about. So you were adding the trauma.
No, it is quite
Ultimately, it
recommended.
would have ended in more complications.
No, it is quite recommended.
Micro forceps is a quite well established form of GSL, so I can't criticize that. It is also on the internet. But I've recently started the cannula thing, I have to admit, and it does work. So you just don't know. Sometimes it doesn't work. You just have to see how that goes.
So I can say that I did not have very good experience with this method, so I feel very comfortable.
Because GSL is a very effective procedure for those patients who come up with angle closure glaucoma and have cataract. And all remember, the lens is first in angle closure disease, so we must remove lens and then do the angle procedure. And practically, it avoids the need of playing pyrotechnic in many of the patients. I would not repeat the points Aisha has mentioned, but just micro to constrict the pupil that will open up the angle and we will then really understand where the signing are. And definitely, blunt viscous section with gel is fine. And cohesive gel, sodium hyaluronate 2% is available in Pakistan. We use that. It acts as a dampener and we can just inject gel when we are having bleeding, so that's we avoid the need of washing again and then going in again. And microforceps should be gentle. If it is non-fluid and gently touching it, sometimes you don't just need to pull down, just touching will help. If not, you can pull it down, and these are also available. And the last thing is, if we see chronic patient, to combine it with abitalotene, just 2 needle depth. That will help to remove the disease from macular mesh further. If it's a chronic, even then it's very helpful. And GSL has to be more than 3 quarters because we know practically we should have half of the angle working. If the pressure has to be low, if we just do it in 3 quarters. And some people just blindly do it with the incision as well without visualization. We cannot do gonioscopy, just do it blindly so that we can have as much of the time. I do it temporarily, so I can have a saving session doing my phaco and then GSL.
So I've been doing this laser beam CPS for almost 1 year now, only laser 180 degree, and till now I'm having very good results. So I did have anatomy in my mind that most of the drainage channels are created on the nasal side. So if you do only 180 degree on the single side, most of the cases it's enough. But I really appreciate your positive feedback that if you do 3 quadrants, it will be more effective. Thank you so much.
The next presentation is mine. I'm working as associate professor in Padmajina Medical University, Sarangaram Hospital, Lahore. This is a presentation of a phacoemulsification, corneal transplant, the keratoplasty with cataract extraction and eye implantation, a triple procedure. Thank you so much. At the end, I would like to thank Dr. Anika, please, who made this video and edited this video with me. And I also want to thank Dr. Uma Kyani, Professor Uma Kyani, who started this cornea transplant and all the setup in Sagamara Hospital and this video recording and everything so that the people can get benefit. So thank you so much, Ma'am Uma. It is all because of your effort, your dedication, and everything. Thank you, ma'am. Okay, next presentation.
I want to add here one. See, your PC was building forward, right? It seems as if there is high pressure. So many times I come across the same situation. I have solved it with the discussions with my colleague fellows. You can prevent it. First, I always put the lid stitches. Then I put the eye speculum. If I feel during surgery the posterior capsule is coming forward, then I remove the eye speculum and leave it only the lid stitches to make the field open. This makes your posterior chamber quite deep. You will immediately appreciate that the chamber has become very deep and you can easily remove the cortex and you can implant the lens.
Very good, sir. Thanks so much. Next time we will.
At 9 o'clock, we kind of jiggle it and the lens comes out very easily because it's an open sky procedure and we have to be very careful and we have to be very quick. So we don't have that much time for the high. We do it, but we have to be very careful. So if we apply pressures at 3 and 9 o'clock, then it comes out very easily. Thank you.
Thank you, Dr. Sharma, for the wonderful input. Next is my very dear friend and assistant professor, Dr. Amnaj Branch. She is working in Lahore General Hospital. She is going to present the video. Thank you, Dr. Farah. This is surgery of the young child.
Begin by placing a lid guard.
Is bilateral psoriasis. The surgeon of one eye. First we're placing the mask and then the stabbing cells.
Two stab incisions are made in the upper lid using limbus as the landmark.
Medial and major limbus, replacing the mask.
Two stab incisions are made at the medial and lateral margins of the eyebrow. One stab incision is made in between the eyebrow incisions at the forehead. BT set needle is passed through eyelid incisions and DCR tube is passed through its pore.
Here we are using a blood transfusion set needle instead of a process eye. Because I think it causes a little less trauma.
Now BT set needle is
much
passed through
easier
the eyebrow incisions, the
the
eyelid incisions, and is passed through. Now we pass the BT set needle from the forehead incision towards the eyebrow incisions and pass the DCR tube through it. Here, both ends of the DCR tube are out from the forehead incision, making a pentagon shape. So we tie these two ends at the appropriate measurements.
You pull them in vertical there with your forceps at the height that is desired, and then we tie a knot so that afterwards when it slips down, we have the required height.
The remaining DCR tube ends are cut and all the stab incisions are sutured.
So it was done on both sides. This is his postdoc picture, and this is my team of residents who work with me. And this was actually a surgery I was making one of my residents learn how to do it for his first time. So the little innovation that we're doing in it is that we're using a BT set needle and stuff. And also, I think to take out fascia lata is a little more invasive and it takes a lot of time and it's more difficult. So for the residents, it becomes very easy to do a good process surgery like this. So that's how I said. Who is principal in Fathers and Medical College, Sialkot, and she is going to present her video presentation of traumatic dialysis and get to women of ophthalmology. It's a pleasure to see a blend of males and females sitting together and listening and appreciating. Special thanks to Professor Sukasa for being here, and a special thanks to Dr. Rita for joining. She is what I know and what I've been introduced for her as that she's the founder of her hospital in Nepal, Telangana, and she is the corneal lady of Nepal, and she is currently. I was told that use this opportunity to sign as many MOUs between Nepal and you. So I hope that you'll be able to do that in future. Thank you so much for the very beautiful arranged balconies and with the shawl. Thank you, Dr. Aisha, for being here. It's good to see, a
combination of all kind of super specialities in one place. And for Pakistanis, I can say as for Pakistani ophthalmologists that we like it said, jack of all trades, master of none. No, we're jack of all trades and master of all. So that's what we're doing right now. Round the eyeball in 90 minutes from anterior to posterior. And whoever is sitting here, though I might be a VR person, but like Dr. Sara said, developed the corneal transplant in Sadanam Hospital and I'm doing that in Naushala in Sialkot also. And cornea has really picked up, not just VR cornea, and we're looking at oculoplastics. We have the medalists sitting on the stage. So thank you, all of you, for being here. And today we're going to talk about traumatic iridodialysis and a complicated cataract in a 7-year-old. A blunt trauma. Imagine it's not traumatic, we're not perforating. A blunt trauma can also create havoc by creating, like displacing the iris and causing a trauma, causing a cataract. So here we go. So this is iridodialysis, repair and replacement, the saving a female child, history of blunt trauma with a plastic bottle. Children are playing all the time. Traumatic cataract and iridodialysis between 5 to 8 o'clock. I have no financial disclosure. So here's a cataract, here's a pupil, here's the iridodialysis between 5 to 8 o'clock. And should we leave it? Should we not? So the important thing is this is a small child and you have to have this because it can cause a diplopia also. Because their future there is like the glaucoma surgeons sitting over, there's a chance of glaucoma in these patients. So to operate on them, I think it's wise if you're going to take the cataract out to repair the iris as well. So for me, I thought it's better to hide the sutures underneath the sclera by making, just like the glaucoma, make two sterile partial thickness tunnels. 2.2 millimeter partial thickness sterile plasma made. And they were like just behind the area where I would suture. So before entering into the eye, it's always good to prepare your sterile bed. As it's a child and it's a case of trauma, so you will see a lot of blood coming. So either you do hemostasis or you let it bleed for the second time. So paracentesis, like the regular PECO, here we use the radio frequency. In Sadanam Hospital, in our department, we do have the facility of radio frequency. So because this is a case of trauma, I did not want to use a cystotome to further pull out the zonions because it's a trauma, it's a dialysis. I'm sure that the zonions will also be slightly broken here and there. So once it's done, before putting the IOL, now this can be debated, we put the IOL first or not. It's debatable. So I thought it's better to just get, and imagine by the time you're taking the cataract out, you're doing it, look at the dialysis, it is extended. Because when you're pulling and when you take this, in fact the lens also keeps it in its place. So when you're taking the lens out, you take a needle, a Proline, which is 80 double needle, and then you take it inside the anterior chamber, pass through the iris, and the other end comes out from underneath your scleral bed or scleral tab that you have created. So it's both sided, one side out, then you take the other needle inside, and then underneath the scleral flap, you tie it. Similarly, because it's a big scleral iridodialysis, so just one can work, but it's always good to complete, if you can try to completely see your iris to its normal anatomical position. Throughout this, please keep in mind that as you're very close to the endothelium, keep your anterior chamber well coated. So once this is done, it's like when I was doing this, I was thinking as if I'm doing a glaucoma surgery also. So a half of track has been done at the same time. And I think conjunctivitis is a blessing to to have a conjunctiva, so always be very careful and spare conjunctiva as much as possible because you will be needing God knows where. So this is a normal beautification of the eye that conjunctiva covers a lot of things. Just even if you have a flap, if you have a button, anything underneath the conjunctiva will cover it. Put an IOL later on, or you can put an IOL at the same time. It depends on the expertise of the person who's doing it. As it's a small child, there's debate whether you want to put in a suture or not. And I think for me it was that I wanted to see the anterior chamber, so I put a 110 nylon suture and fill the eye and close the eye with air paracentesis. So thank you so much for listening. Thank you for watching, and thank you so much for being here, especially
Dr. Baf Daniel Khan, who is a senior training medical officer, third year training at Hyderabad Medical Complex, Peshawar.
For having me here. I'm Dr. Bhaftania Khan, Senior Resident from Hyderabad Medical Complex, and I'm really grateful to be presenting on this forum of empowerment and opportunity. My topic is a phakic IOL, and I have dubbed on it, so you guys don't have to listen to me twice. And let's start.
But a genuine barrier to daily life. This young man, 27 years old, arrived determined to get rid of his glasses, frustrated by years of imbalance by his refractive asymmetry. He had a -2 in his left eye and a -15 in his right eye. The significant refractive asymmetry had major implications for surgical planning. The 15 was beyond the treatable limit for corneal refractive surgery, and the corneal parameters did not allow safe tissue removal for days. We considered refractive lens exchange, but a multifocal intraocular lens cannot be implanted unilaterally. A monofocal lens would remove his natural accommodation, which he needed for his daily job and activities. This left us with only one sound scientific option: a phakic intraocular lens. The process of implanting phakic IOL begins with loading it into the injection cartridge. It is pre-filled with visco, and the IOL is put between grooves on both sides of the cartridge. The IOL has landmarks on its optics and haptics, as well as a convex shape. A specialized forceps called the ICL loading forceps is used to drag the IOL to the tip of the injector. Alignment is made certain. The cartridge is snapped into place on the injector. After one final look, we can be ready for implantation. The surgery begins after draping the patient, and incisions are made at 6 o'clock and the 12 o'clock. The main incision is made temporally because of ideal exposure, and it is about 3 to 3.2 millimeter wide. Visco is used to coat the cornea, and viscoelastic is injected into the anterior chamber. Care must be made not to overinflate the chamber. The injector is inserted through the temporal incision, and the IOL is delivered through a slowly advancing technique. At this point, the anatomical landmarks of the IOL will become prominent. A mark at the leading right edge helps ensure the right orientation of the IOL. After about half to 2/3 of the IOL has left the injector, it will start to unfold. In the beginning, care should be made not to directly put the IOL onto the lens because of inadvertent capsule touch. Each of the corners of the IOL can later be adjusted into position. This is a patient and careful process, and while we wait, let's look at the indications of a phakic IOL. WIOP starting as low as -0.5 diopters to -18 diopters, as well as those patients who cannot undergo laser vision correction due to thinner corneas or dry iris factors are suitable for this procedure. Contraindications included at patients with an anterior chamber depth of less than 2.8 mm, with an anterior chamber angle less than grade 3 as determined by bronchoscopic examination, patients less than 21 years of age, or pregnant or nursing, a low or abnormal corneal endothelial cell density, previous pre-existing ocular disease, patients who are amblyopic or ocular hypertension in either eye. The round iris signifies that the IOL is in its place and free from the iris. At this point, my cord has already been injected and the anterior chamber is washed out of viscoelastic material. A thorough wash ensures that there will be no post-op inflammation. The ports are hydrated and the surgery is complete. I would like to thank my supervisor and my colleagues for their help in making this video. Thank you so much.
Next is Professor Shabana Chaudhary. She speaks about pediatric eye exam available.
So, sir, playful video children. It's always difficult for my colleagues to examine the child. So let's have some tips and tricks. Child should be lying comfortably in mother's lap. Examine the child. Disclaimer is consent is taken to show to check the views of these children. So if there is any extraocular restriction, go for the abductions and then do the God's eye movement to see the so difficult is to do the extraocular movement. So if there is any restriction, go for the God's eye movements, but tip is that do the God's eye movement because you have to just give the jerk to the head. So do it in the last. Just write it down that you will do it in the last of your child examination. क्योंकि बच्चा अगर रोएगा तो फिर बाकी का एग्जामिनेशन आपका नहीं हो सकेगा. तो अगर हम बच्चों को जो इंस्ट्रक्शन देते हैं वो ये पेरेंट्स को देते हैं कि जब आपने बच्चे को एग्जामिन करवाना है तो एक तो वो 6 घंटे पहले जगा के लेकर आए ओपीडी में. ठीक. और उससे ये होगा कि जब बच्चा आपके पास पहुंचता है वो इतना टायर्ड होगा कि वो सो जाएगा. The second tip is that कि बच्चे का पैम्पर जो है वो साथ लेकर एक्स्ट्रा. अगर बच्चे का कोई आपका बॉटल से दूध पीता है तो बॉटल साथ लेकर आए, पेसिफायर साथ लेकर आए और बच्चा जो है वो आराम से कंफर्टेबली मदर के लैब में होगा तो एग्जामिन कर लेगा. आप एग्जामिनेशन कर देंगे. बच्चे के जो रिलेटिव्स हैं जो एक्सटेंडेड रिलेटिव्स हैं उनके बजाय मदर को प्रेफर करेंगे. बच्चा जो है वो मदर की गोद में हो. अगर बच्चा आप उनसे पूछ लें कि किससे ज्यादा क्लोज है. कई दफा जो होता है वो फादर से ज्यादा क्लोज होता है तो आप उनको कहेंगे फादर को अंदर बुला लें और उसकी गोद में बच्चे को दे दें और एग्जामिन कर लें. देन मस्ट बी अ सीक्वेंस. आपने देखा होगा कि पहले हमने उसमें जो है रियल इक्विटी असेसमेंट की, रियल बिहेवियर. जब बच्चा नॉन वर्बल बच्चों में हम रियल बिहेवियर देखते हैं बिकॉज वी डू द क्वालिटेटिव real assessment and we can't do the quantitative real assessment. So in most of the centers in Pakistan जो quantitative real assessment है उसके gadgets जो हैं वो available नहीं है उतने ज़्यादा frequently. तो हम उनको कहते हैं कि real behavior आप check कर रहे हैं and it's very easy to check the real behavior. It's just that you just cover the eye and see for the objection to the closure of either eye. And by doing that, try not to touch the child. Just cover the eye, and it must be away from the face. Don't touch the face because आपका unfamiliar जो touch होगा वो बच्चे को irritable कर सकता है. तो आपने बच्चे की behavior को आप just simply इसका करें और follow fix को आप जो है जब आप torch के साथ करेंगे या phonoscope के साथ करेंगे तो आप note down करेंगे. Next जो step आता है extraocular muscle का वो हमने बता दिया. Next जो है don't forget to do the inspection as well as the pupil examination. Don't forget the children.
चाहे बच्चा जितना भी छोटा हो उसका बिल्कुल एग्जामिनेशन शुरू करें. Anyone who will tell me that on inspection, what are you seeing at this child's face? On inspection. Yes, there is a scar on the forehead. So what are you expecting? There must be a history of trauma, and now look at the. So if you don't do the pupil examination, you are missing something. So this is that how the different ways to calm down the child. So there was one way that one way is that give the हमारे यहाँ पे गांव में या दूध में बच्चों को झूला देते हैं. तो पेरेंट्स को कहीं झूला देकर सुला दें अगर बच्चा नहीं सो रहा. ठीक है, आप अपने साइड पे बाकी अपना एग्जामिनेशन करते हैं. जब वो बच्चा सो जाए तो आप उस बच्चे को एग्जामिन करते हैं. देन अगर बच्चा जो है मदर की गोद में है, यू कांट एबल टू एग्जामिन द चाइल्ड, आप अपना पोस्चर चेंज कर लीजिए. आप खड़े हो जाए, बच्चे को माँ के साथ लगाएं या बाप के साथ कंधे से लगाएं और आप अपना पोस्चर चेंज करें, एंड यू कैन डू द indirect ophthalmoscopy very easily. So there are different ways of doing the indirect ophthalmoscopy. और बच्चे को हमें यहाँ पर वाटर फिट लग गया हुआ है और हम उसको एग्जामिन कर रहे हैं, इंडायरेक्ट कर रहे हैं. Yes, we don't need the handheld of a slit lamp. We can even with the posture change, we can examine the child. A slit lamp examination we can do on a slit lamp जो हमारे सब clinics में होता है. अगर बच्चा जो है uncooperative है, again we will suggest change your strategy and examine the child where the child is comfortable and change your gadget as well. So here this child was with delayed milestones, and so it was difficult to set her up on the slit lamp. We changed the strategy and we get a result. Again, for the retinoscopy, you can there should be a dark room, and then you can do the retinoscopy. And there is a misconception that the kids they are uncomfortable with the glasses and they don't wear the glasses. So here is a child, a baby of. We did the cataract surgery bilateral. We examined the child with the glasses on. Remove the glasses and see the child is crying, and now. So don't forget to prescribe the glasses to the child with ये मत सोचिए कि बच्चा जो है नहीं पहनेगा. It's all counseling. बच्चा नहीं पहनता है. There is another child. He came to me at the age of 3 months with a real inattention. इसलिए खामोश होकर के आप सुने कि वो बच्चे दोनों से मुझे कहने से अच्छा नजर आता. Now he is 4 years old child. और वो आराम से अपनी एनर्जी है वो पहन रहा है. That's it from me. Thank you.
Thank you so much, Madam Shabana. The next presenter is Dr. Alina Khan. She is going to present with stepwise lower jugal flap. Dr. Alina. Assalamualaikum. I'm Dr. Alina Khan. I've recently finished my second fellowship training from Hyderabad Medical Complex. Today I'm presenting this case of a lower leg basal cell carcinoma, in which we have done the excision as well as the reconstruction with a multi-step procedure. So this gentleman presented with a lower leg basal cell carcinoma, as you can see. This mass excision was done and about 70% of the eyelid was removed. Thankfully, we had the medial as well as lateral campus, but this large gap was present, for which we planned to do a new tarsophalangeal dilate from the upper eyelid was taken. Upper leg is inverted, and the flap is marked. About 3.5 millimeters of the tarsal plate is left towards the eyelid margin, so as to support the upper eyelid. Marking of the flap is done. And rechecking along with the size of the defect is done again. Here we're also marking another flap, that is the nasojugal flap that will be used to cover the skin defect. You can see the dissection of the used flap in this part of the video. The tarsoconjunctival flap is raised from the upper eyelid. And now we're beginning to raise the nasojugal flap from this region to give it the skin cover as well. Now things are about to make some sense. We start suturing the skin flap first, opposing the angles of the flap together and leaving the nasojugal flap, which has to replace the lower eyelid skin. So the main defect on the nose is closed. Now we turn our attention towards the eyelid. Where the wound preparation is done and a stepwise suturing of the two flaps will be done. Here we are separating the layers of the lower lid. Anterior and the posterior lamina are being separated because what you want to do is you want to suture each and every layer of the used flap with the same tissue in the lower eyelid. So you suture the conjunctiva to the conjunctiva and the tarsal plate to the tarsal plate to make it anastomose properly. Hemostasis is secured because now we are closing the skin layer as well. This is the nasojugal flap that was raised earlier. It is being brought laterally to cover the lower eyelid skin area. You can see how well approximated it is at this point. And so going ahead, this upper part of the flap has to be sutured with the tarsal plate as well. Do not leave anything to chance. You want everything to be in the place that you desire it to be. This is the final intraoperative appearance of the wound, and this is the appearance 2 weeks later. So as a next step, we are going to divide this flap now. As you can see, the flap has taken its place very nicely. This is the division of the used flap going on. We pass a spring hook underneath the flap, raise it and then cut it, divide the flap. We try to leave as much of the conjunctiva towards our lower wound as much as possible because we want to sort of fold it over the lower eyelid margin that we have created now. So this is the final appearance of the reconstructed lower eyelid. This is the post-operative appearance of the gentleman. Thank you. Thank you so much, Dr. Leena. The next speaker is Dr. Iram Zuraza, who is also a very good friend. She has come from Multan. She is a consultant ophthalmologist from Government Shabaz Sharif Hospital, Multan. She will go. Hospital reports are being made. During vitrectomy is meant to remove the adhesions around the drop iron. Iron feeds on the adhesions and is drawn upwards. Taking place to go for the fixation. IUL is to know. IUL is being tied. The wound is being closed. The vesicular vitrectomy. And finally, closing the pores. And the channel finally. Thank you, Dr. Ram, for the wonderful video. Now we are left with only two presentations. Next is Dr. Amitabh College. She is assistant professor in Golan Medical College, Helpers Eye Hospital, Kolkata. She will going to tell us how she tackled region.
Good morning, everyone. Today I'll be sharing my approach to managing pterygium, whether it's primary or secondary. I chose this topic because I strongly believe unless we treat this don't treat this common ocular surface problem efficiently, we cannot move forward for advanced surgeries such as cataract and the refractive surgeries. So my technique is very simple and economical. The first step is always pterygium excision, and I use fraction method, and I remove first the head of the pterygium and smooth the surface, rescue the surface, and remove extra tissue with precision knife. And I always remove some extra non-capsule and normal conjunctiva because it's considered as the culprit for recurrence. After measuring the dimensions, I take the graft from superior bulbar conjunctiva. It's very important to release all adhesions from conjunctiva and Tenon's capsule and take a very thin autograft from superior limbus without disturbing the tenon, and care should be taken not to make any buttonhole in the graft. This technique is very simple and economical without use of any suture and glue, which is not available in our area. So gently raise the graft and excise it at the limbus. And care should be taken not to miss the alignment, the proper and correct orientation of the graft, for which is placed over the cornea with upside down and spread it on the cornea. Then rotate and drag it at recipient side. Align the limbal to limbal orientation. Use plain forceps and hold the other edges and flip it over the recipient side. For this technique, we use serum as bioadhesive, and for the serum, there is no need to send the blood to the lab. Just prick the episcleral vessel and allow the blood to collect over there and remove the superficial clot and place the graft and smooth it with use curved forceps for smoothing and ironing, and bring the edges under the recipient conjunctiva, and then put the eye drops combination of steroid and these are post-operative, and patch the eye for 24 to 48 hours depending on the size of the graft and recipient side. Now what I do recurrence, I haven't seen any recurrence with this technique, but we deal with the recurrent cases on daily basis. For the recurrent pterygium, I use intralesional 5 fluid resist, so 0.1 to 2 ml, and it is an OPD based technique. I just inject it into the recurrent pterygium on weekly basis. The number of injections can be tighter according to the dose and the response. What is my aim to in treating the recurrent pterygium to get an atrophic and atrophic pterygium and bring it in static position and stop the progress. So take home message from this presentation is pterygium excision with autograft is the gold standard method with
lowest risk of recurrence. Autologous serum is good biological adhesive alternate to glue and it's very good for low resource setting, and it's easily available with shorter surgical time without need of any special equipment and technique. And in cases of recurrent pterygium, repeated surgery itself is a risk factor for recurrence. So, avoidance of surgeries by means of pipe hydrocele confers the advantage of less scarring, reduced risk of intraoperative and post-operative complication. It reduces the difficulties associated with harvesting more tissues from limited donor site. The most important thing in managing pterygium excision is close follow-ups after primary pterygium excision, because early detection of recurrence at early stages and commencing the treatment in early stages, the results would be better, more better. Thank you so much.
This is Dr. Maria Nazish Mehmet. She is Associate Professor, Institute of Ophthalmology, WIOP, University of Medical and Health Sciences, Johnshore. She is going to tell us the video and discuss the video about management of anterior lenticonus with ruptured capsule.
Thank you, Dr. Sara. Assalamualaikum, good morning everyone. We are just running short of time, so I'm just going to go through the video. Basically, 12 years were presented with a grateful vision since 1 year, and the visual acuity is counting finger in the right eye and 20/70 in the left eye. There is no improvement with reflection, and this is the picture of the right eye, undilated and dilated picture of the right eye. Basically, the child is having a spontaneously ruptured anterior capsule with the lens matter coming out of the capsule and in the anterior chamber. And this is the picture of the left eye, dilated and undilated. There is a spontaneously ruptured anterior capsule, and the margin of the capsule is obstructing the visual axis. That's why the vision is not improving, although the lens is comparatively clear. So the diagnosis of the anterior lenticonus was made, and as we know that the anterior lenticonus, most of the time the patient is having Alport syndrome. So the patient is having hearing problem and a renal problem as well in this patient. So this is a video. So in this case, two posts were made at 2 o'clock and 10 o'clock with MVR wave. There is 10 gauge MVR wave. One is for the self-retaining anterior chamber maintainer, and the other is for the refractory cutter. And basically, the main point here is we use the cutter to make the lenses in the anterior capsule because it is a five-party capsule, and we are planning to implant the lens in the bag. So after aspiration of the lens matter with the help of the cutter on aspiration mode, we just with rectovexis in this patient to make a circular opening in the anterior capsule. So this is a rectovexis. We just make a round opening in the anterior capsule to implant the lens in the bag. So cutter is a very beautiful tool, not only for the vitrectomy but for the rexis as well. So the polymer lens is implanted in the bag and wound closed with strong hydration. So this is a post-op picture, 6/9 vision in the right eye and 6/6 vision in the left eye. Thank you so much.
Thank you so much, Dr. Maria. Here our session is going to end now. This was the last presentation. At the end, I would like to thank Professor Sultan for coming for the session. Thank you so much, sir. And Madam Rita for coming for the session. And Professor Abdul Salam, who has come from Ahmedabad. Thank you so much, sir. and Dr. Irfan, who is my senior, he's also come here for the presentation. Thank you, sir, for coming. And I would like to request all the presenters and the seniors to please come here to have a good picture, please. Thank you.
Okay, dear colleagues, ladies and gentlemen, good morning. So, for the next 10 minutes, I want to talk about the positioning and trimming of ML glaucoma valve tube, which causes the problem with the cornea. So, no conflict of interest with my presentation. So, the frequency of glaucoma drainage devices in cases of medically improved glaucoma has been increasing worldwide. According to 2012 tube versus TRAB study, tube shunt procedures showed comparable IOP reduction and higher success rate over 5-year follow-up. Corneal decompensation was one of the common long-standing complications of glaucoma drainage device implantation with devastating visual consequences. TVT study also showed that 16% of tube patients develop persistent corneal edema, with 8% cases undergoing keratoplasty over 5 years of follow-up. The Ahmed Barwell comparison study found corneal decompensation rate of 20% during 5-year follow-up. One of the most significant complications associated with intermittent or persistent tube corneal touch is corneal endothelial cell loss and corneal edema. This complication has been observed in up to 20% of the patients during long-term follow-up. Patients exhibit a scar with shallow anterior tumor, corneal cataract, corneal edema, and eyes with corneal transplant. Various causes have been proposed as mechanism leading to corneal endothelial cell density reduction related to tube surgery. This is foreign body effect on the silicon tube, progressive tube migration, peripheral anterior staining deformation, and transient tube corneal contact with blinking and rubbing. So you can see, this is what we see. The very well tube company almost crossing the entire anterior chamber, and that's where it causes the problem. Overlong tube risk corneal endothelial damage, iris irritation, and tube occlusion are eligible. Why corneal touch happens after AGV tube? Tube is trimmed too long and re-inserted at an improper angle. Bevel direction is incorrect. Bevel should be facing up to direct flow away from the cornea. Antechamber anatomy is altered, and patients have shallow anterior chamber and iris abnormalities. The tube is not secure where allowing anterior migration, and then a poor scleral tunnels construction. If two anterior are shallow, tube can tilt towards the cornea. Post-operative scarring or movement shifting the tube forward. And the result is endothelial cell loss, persistent inflammation, corneal decompensation can lead to villus neuropathy, increased risk of tube failure or need for keratoplasty, and then even brief or intermittent contact can cause damage over time. So the treatment options, medical, we reduce inflammation and monitor closely. Then there is surgical revision. Tube positioning, withdraw and reinsert at a deeper angle, use a new muscular entry track, possibly position tube into posterior chamber, especially patient is pseudopicket, cerebral sulcus, if the lens is intact, or pars plana, if patient has undergone vitrectomy. So we are describing here two surgical techniques for repositioning and trimming of AGV tube causing corneal endothelial touch with corneal edema resulting in reduced vision. And this is the first video that I am showing you. Now this patient already had a well there, you can see it, that did not work, so he came to us and I put a second well, and 6 months after he came with reduced vision. You can see the tube is longer and it's touching the cornea, he had a corneal edema. So his vision was basically about 612, 618 and dropped to almost less than 660. And so this is the simple technique. Here the cornea is clear, so what you can do is you'll see actually the video, it's just 2 minutes video. We form the anterior chamber with viscot, which will cover the endothelium, and the surgery is done under topical anesthesia. Or by the way, it's from an edipinic, I just said with apple cover. So I have to use a vitrectomy instrument because they are longer in the length, and from one side you enter the faucet that you want to hold it. The problem is that you have to hold it. Again, you can cut it from the other side. Left hand से मैंने होल्ड किया, राइट हैंड से मैंने असिस्टेंट ने किया। वो जो मैं सब देखा वो नजर ही आ रहा है, वेरी डिफिकल्ट फॉर असिस्टेंट टू नहीं वो तो करते तो लेफ्ट हैंड को आगे बढ़िए, and then you reform the thing. So before surgery, the patient's vision was less than 660 and improved to 680 afterwards. This is a other technique. ये मेरी बात हो रही थी कि ज़माने में last year with Uma, and now this is the problem. Cornea is not clear. I can't see it. तो मैं दोनों तरफ से कैसे जाऊँ? ठीक है ना, मुझे नजर ही नहीं आ रहा. तो देखिएगा, this is actually very simple technique. With the 2.2 knife, I just go in the anterior chamber on top of the tube. चल जाएगा. This is again surgery done under topical. And then with the utrata, I grab it and bring it out. ये बाला है. आपने इसको काट दिया और इसको push it inside the arm. आसान है. तो वो cornea clear होती है. You can imply that if cornea is not clear, you're not sure, and then you can do the others. Doesn't take more than a couple of minutes. This is the patient before surgery 636 and 69 improved afterwards. So there are certain steps and tips to achieve ideal tube position. Prepare and fix the plate correctly. The plate of the AGV is sutured about 8 to 10 millimeter posterior to the limbus, typically in the superior temporal quadrant. Why we put it in the superior temporal quadrant is because number one, there is no superior oblique muscle. The optic nerve is further away from it, and temporally if you feel it longer, so the patient sometimes cannot see it. So that's the ideal position that we put the tube in. Ensure the plate is well seated under T-Norms capsule and conjunctiva without tension. This determines the length of tube trajectory. Measure and lift the tube. Before inserting, send the tube so that 2 to 3 millimeter will project into the anterior chamber once inserted. By the way, जो बच्चे आते हैं 6-7 साल के उसको ट्यूब डालते हैं तो उसको ट्यूब थोड़ा सा लंबा डालना पड़ेगा because over the year when the child eye is growing up, the tube gets shorter. Recently I've seen a बच्चा जिसको मैंने 8 साल पहले डाली थी. आप उसके anterior chamber में ट्यूब देख ही नहीं सकते. Then you put a bony lens. If I put a bony lens, pressure is fine, 12 millimeters of mercury. But when I put a bony lens, I can see the tube. You can see there. Okay. So advice करते हैं कि बच्चों में थोड़ा सा लंबा चौड़ा होता है. So before inserting, trim the tube 2 to 3 millimeters will project into the anterior chamber once inserted, and cut people up with sharp pen or scissors. Avoid long tubes that can touch the cornea iris and too short tube may react. ये भी प्रॉब्लम है. बहुत थोड़ा छोड़ेंगे तो प्रोटेक्ट हो जाएगा, आपको नहीं आएगा. Create a proper explainer tunnel. Use a 23G needle because especially when you are doing this taking to make an empty sac is about 2 millimeters to the numbers. So I use 25 needle and उसके ऊपर थोड़ा सा जेल लगा देते हैं तो आप फिश कर सकते हैं. लेकिन overall I find it difficult. So मैं 23 ही कर रहा हूँ because the diameter of 23 needle is 0.3 millimeter and the same is with the AGV. So उसमें loose नहीं होता. The only problem is that if there is a fluid coming through your tract, then patient can go into abortion later on. Direct the needle parallel to the iris plane, and the tunnel should enter the anterior chamber just anterior to the iris position. Gently insert the tube through the tract. Verify that 2 to 3 millimeter tube is inside the tube. So confirm the position. The tube should appear centrally placed, lying parallel to the iris, not touching corneal endothelium or iris. How do you ensure a calm position? You have to do the endoscopy. Ensure that tube tip enters anterior to the slit spot. In opaque cornea, difficult, so you can do the anterior segment OCT or even UVM. So there are surgical first surgical tips. Movement of tube has to be restricted under the flap either by applying cooking glue. So जब आप flap बनाते हैं ना, तो normally क्या होता है कि if I'm putting an extra scleral on the tube, तो वो बाहर से आता है, मुझे $300 का होता है. मरीज पहले ही इतने पैसे देता है 300 डॉलर की तो मुझे इजी पड़ती है तो ये ज़्यादा प्राइस बढ़ जाती है सो आई हैव टू मेक अ नॉर्मल स्लीव फ्लैप ऑलमोस्ट 5 into 5 जैसे हम प्लान में करते हैं और ट्यूब उसके अंदर से पास करके मैं कवर करते हैं ठीक है जी सो मेक श्योर दैट इट्स सील पोस्टीरियरली तो सील करने के लिए यू पुट एक्स्ट्रा suture or you can even use the hookah. So alternative stay suture is applied because movement को स्ट्रेट करने के लिए आप टेनोनाइलॉन का stay suture लगाते हैं जो मैं नॉर्मली लगाता हूँ. The tube applies 2 to 3 mm inside the anterior. It should be parallel to the iris plane away from corner D mm length. A direct bone is taken in the diet that can help you. And in pseudophakic eye, we can perform implantation in the posterior chamber between iris and implanting. So pseudophakic eyes may normally prefer to put it behind the iris. उसमें क्या होता है कि tube has to be slightly longer that you can see the tip of it in the pupil. कभी-कभी ये भी हुआ है कि पीछे रहेगा iris उसको प्लग करके बंद कर देता है. So make sure that you see it in the pupil. In phakic eyes, posterior peripheral anti-synechies and shallow anterior chamber, tube can be placed in the posterior chamber after performing cataract surgery. तो अगर आपको जगह नहीं है पीछे pseudophakic नहीं है तो क्या करें? You remove the lens and then put it in the posterior chamber. And this is the case, especially last time of Shah पीछे बैठी हुई है तो इन्होंने इस्लामाबाद में एक केस दिखाया था this patient had eye syndrome anterior chamber was very shallow patient's pressure was not controlled so what she did was she did the phaco remove the lens और उन्होंने इसी का ट्यूब का पीछे डाल दिया है तो मैं उनको बता रहा था एक तस्वीर मैंने उनको भेजी थी कि मेरे पास सेम पेशेंट आया स्पेस on one side तो मैंने डाल दिया but you can remove the lens. So in patient with absent posterior capsule or secondary sleeve fixate IOL intravitreal placement of tube can be done after thorough angiotectomy to prevent vitreous stent blocking the tube. So what is the take-home message? If GDT tube causes coronary touch, early intervention, ideally surgical repositioning, is often necessary to protect the cornea and maintain vision. If not corrected, long-term complications like neuropathy can occur. So achieving the ideal position of AGV, WIOP or any other GDT is fundamental to the surgical success and long-term outcome. The tube should enter the anterior chamber 2 mm posterior chamber, directed parallel to the iris plane, bevel up and extend not more than 2 to 3 mm in the anterior chamber, maintaining a safe distance from both the cornea and iris. Meticulous attention to these results along with proper plate fixation, accurate tunnel creation and secure tube coverage help ensure effective drainage, stable intraocular pressure and reduce risk of complication. By following these key principles, we can maximize the functional longevity of the implant and preservation outcome for the patient. And this is the beautiful beach in Karachi. मैं सबको invite करता हूँ कि जब आप लोग आ जाएं, we'll have a beach party. Thank you. अगर कोई सवाल है तो मैं जवाब दूँ, otherwise हम
How can you use
ब्लू तो लैब बनाता है उसमें बनाते हैं तो ट्यूब पे जा रहे हैं तो यू मेक श्योर कि आप ब्लू पे डालते हैं तो बैठ जाए समटाइम वो बाहर जाता हूँ काउंटर्स में ले आता हूँ यहाँ नहीं लेता और अस्पताल को नहीं बताता मैंने डालती है कॉमन उठेगा फिर लैब से पास कराया नहीं कराया नहीं कराया लगाते हैं नहीं है तो आप फिर मैं नाम से क्लोज कर देता है आइडिया ये है कि फ्लूइड को नहीं आए बट अदरवाइज पेशेंट हैज that's it. That's the whole idea. लंबी जाने का मतलब ये है कि आप 2-3 मिनट डालते हैं उसको एक आधा मिनट ज्यादा डालते हैं तो थोड़ा सा लंबा लगता है लेकिन ओवर द इयर्स यू विल सी अगर आप शॉर्ट डालेंगे ना तो आपको 5 साल के बाद नजर नहीं आएगी राइट
Thank you for again this excellent talk. Just one question on that. Have you had any experience of tube exposure, as during melt? Because that we do get fairly commonly. Have you had
tube melt? Yes, of course. Over the years we have been doing AGV. If you do AGV, you see the tube melt. You see the flare. Tube अगर melt होता है, exposure होता है, उसको cover करें.
What do you know?
I use the stored sclera. Stored sclera करके बंद करें. लेकिन unfortunately, the common factor that I have seen in the patient who have a tube exposure is the dries and uncontrolled diabetes.
There's also the deep sockets.
Dries, problem.